So hi, everyone. This is our December Artificial Intelligence for Clinicians, AI4C, last one of our 2024 session. And we are delighted to have Dr. Safwan Halabi, who is here from Northwestern University and Lurie Children's Hospital. And he's going to talk about pediatric imaging, AI and pediatric imaging, which is somewhat of an underrepresented area of research, and I think almost neglected area. So we're going to hear some of his thoughts around that. As you know, this is every second Thursday of the month from September to May. We take the summer off. And as I mentioned today, we have Safwan, and then we have a great lineup coming for the winter and spring. Tessa Cook from University of Pennsylvania in January. Pranav Rajpukar from Harvard Medical School in the Biomedical Informatics Department. Ian Pan from Brigham and Women's Hospital, who's one of our wonderful residents and also an exceptional data scientist. And Hari Trivedi from Emory. As you know, you can view our past recordings at that link, and that link Carrie Ann has put in the chat. So go there, and you can also fill out the survey. So please do that. That will help us improve our series or bring to you things that you may like to see. As I mentioned, you can watch the recordings anytime, and you can follow us on LinkedIn, Twitter, and so on. Today, as I mentioned, we are delighted to have Dr. Safwan Halabi. He received his MD from the University of Toledo College of Medicine in Ohio. And then he did a residency in diagnostic radiology at Henry Ford Hospital in Detroit, Michigan, and fellowship in pediatric medical imaging at Cincinnati Children's Hospital, the medical center in Cincinnati, Ohio. He's board certified in diagnostic radiology, pediatric radiology, and clinical informatics. So he's one of our informaticist colleagues. Dr. Halabi is currently vice chair of radiology informatics. He's director of fetal imaging at the Chicago Institute for Fetal Health. He's an attending physician in radiology, section head for fetal imaging, and associate professor of radiology at Northwestern University, the Feinberg School of Medicine. He clinically, he practices fetal and pediatric imaging at Lurie Children's Hospital, and his clinical and administrative leadership roles are really directed at improving quality of care, efficiency, and patient safety. He's very passionate about that. He's led strategic efforts to improve enterprise imaging platforms at the Lurie Children's Hospital, and he's been a very strong advocate for patient-centric care. He's helped guide policies for radiology reports and releasing images and reports to patients. His research areas of interest are both clinical and informatics. He studies obstetric imaging, fetal imaging, imaging informatics, clinical informatics, and patient-centric healthcare delivery, as well as artificial intelligence and deep learning. He's served on numerous national boards, the Radiological Society in North America, the Radiology Informatics Committee. He's been a member of that. He's chaired the RSNA Machine Learning Data Standards Committee. Very important. The data standards are how we embed these tools into the point of care applications that people use. He's an associate editor for the Journal of the American College of Radiology, and he served on the board of directors for the Society for Imaging Informatics in Medicine. He's received the Imaging Informatics Innovator Award from SIM and the CAFE Best Scientific Paper Award from the Society for Pediatric Radiology. So we are really delighted to have him today to talk about his title is Image Intelligently, AI Applications and Challenges in Pediatric Imaging. So Safwan, I'm going to go ahead and stop sharing and let you go ahead and share and take it away.
Great. Kathy, thank you so much for the kind introduction and a lengthy introduction. I'm going to go ahead and share my slides here. And I wanted to thank all of you for coming in on this webinar. I know it's during your lunchtime, so please just sit back and enjoy the conversation. And hopefully, please add any questions in the comments section, and we'll get started. So my objectives today are to describe the current state of AI in pediatric radiology, to discuss the interpretive and non-interpretive AI applications, to talk about the challenges in creating and implementing AI into for pediatric patients, and then talk about the strategy and plan to promote this development over time. And I'll end with talking about the Image Intelligently advocacy campaign. This is the most current white paper that's in the JACR regarding artificial intelligence in pediatric patients, and I'm going to summarize some of the key components of this white paper for all of you. And one of the big issues, and I think one of the neglected issues, as Kathy mentioned in pediatric imaging, is that we don't treat children as adults, and that's sort of the classic statement that children are not small adults. So the size, we image everybody from the fetus to the premature neonate to all the way to adolescent bariatric patients, and we often continue to follow those patients with congenital diseases as adults. There's changes in the organs as well as the skeletal system that are different, and things like metabolism and perfusion also are very different. And as many of you that are in the medical imaging space or residents or radiologists know that the newborn chest has an organ like the thymus that isn't there in adults, or it actually goes away over time. So the other aspect, and many of you heard the Image Gently campaign, where we're trying to reduce the radiation dose to patients and also try to eliminate any ionizing radiation that they may be exposed to, because they are more susceptible to long-term effects of that radiation. But what that does, though, when we reduce the image ionization, we have noisier images. When we reduce, let's say, MR sequence time, we have less data, around that imaging. So there are things that go against trying to create, pixel-based algorithms. And this is just an example of a head CT, where you can see it's quite noisy with some of the techniques that we use to reduce the ionizing radiation. In regards to what's currently available as far as AI algorithms, there are very few. You could probably count them on one hand that are pediatric-based, FDA-approved AI algorithms. Nearly all the data sets and all the data that is used to create algorithms are adult-based. Many of the tools, including, as you can see here, pneumonia, spine fracture detection, intracranial hemorrhage detection, brain tumors, PE, lung cancer, are all created with data sets with patients that are greater than 18 years of age. The other thing that goes against all of this work is there's a significant shortage of pediatric radiology subspecialists that provide the labeling of these images. And so this sort of the data sets that need oversight by peds radiologists is very hard to come by. Also, the AI pricing and licensing are often volume-based, and many practices that have pediatric populations don't have as a high volume, so that acts as a disincentive for developers to create AI algorithms for pediatric patients. There are protections. So one of the things is getting access to the data, as many of you have tried in your institutions to get access to images or reports. There are more stringent or more conservative precautions around pediatric patients, including regulatory requirements and also consent. This is a conundrum that many privacy and legal institutes within health systems have, is who gets to consent for pediatric patient data, what happens over time, what happens when they become 18 years of age, and then the retention policies of their imaging. One way to ameliorate that is to allow algorithms to go in between institutions, and a lot of this work has been done at Mass Brigham regarding federated learning. So trying to keep the private data and patient data within the institution. And this idea of federated learning is allowing imaging and also data and the algorithm to go in between institutions without revealing PHI and not having to do a lot of de-identification. So just having local nodes where this can be tested. But again, you have to have very savvy and sophisticated institutions to participate in this federated learning. Now, where can we apply AI? And I'll talk about, hopefully just give an overview of all the different areas of medical imaging. I know this has been discussed in previous talks, but I wanted to maybe give it more of a pediatric flavor. So everything from the ordering, physician or the consultation, the scheduling, the image acquisition, the post-processing, the analysis, the interpretation, reporting, communication, and then management of patients. Where can we apply AI to these different areas? There is a nice paper out of the Great Ormond Street Hospital. I will be mentioning Dr. Shalmerdine, who is writing the Consensus Society statement, and I'll be discussing that draft of multiple societies that are pushing for additional awareness around pediatric AI. So predicting and recommending appropriate screening and surveillance imaging, electronic health record integration. So we're starting to see in our EHRs these AI co-pilots that can help us basically synthesize all the patient information and provide recommendations, and including family history, genomics, wearables, all of that data that is being input into EHRs and coming from the patients themselves. And then hopefully changing the outcomes both on an individual level and a population level. There has been a lot of work on appropriateness and decision support over the last decade. There are shifts in regulations now where it's not being mandated anymore, or at least there aren't incentives to use this type of appropriateness scoring. But we are seeing with generative AI and other ways of determining appropriateness using AI. So this is a huge area of doing the right test at the right time for the right patient. Optimizing patient appointments. We have what's very interesting in a lot of adult centers, you have these like very discrete 40-minute time slots for, let's say, MR procedures. We just don't have that luxury in peds because of the different things like anesthesia that's required, child life specialists, making sure that they're watching a movie or being comforted during their examination, which can take up to, multiple hours sometimes, depending on the complexity. So we don't have that luxury of having the ability. A lot of this is customized, and it fluctuates day by day. Dr. Andriol is on this paper regarding, automatic protocoling or automating protocoling. So imagine using these the LLMs or co-pilots within our EHR to look back at the history and really automate protocoling and determine what the right study is without human intervention. And as many of you know, a lot of the pediatric workflow is human dependent because we check images, we protocol all studies, because there is a high risk of performing the wrong study or not giving contrast or giving contrast for this population. Things like denoising images. So image quality can improve significantly using some of these AI techniques. And you can see here, we deal with a lot of motion issues with our patient population because of things like this. As I don't even have to put on the sound for this, but you can see here, this is probably why many of you have not gone into pediatric radiology, is the concern of the crying child or dealing with the parents. So this is why AI can help at least with the motion issues and other things related to the pediatric patient in the CT scanner or the MR suite or even in the ultrasound suite. Again, reconstruction. This is again has been shown time and time again to help denoise or provide better reconstruction of imaging, like a knee. So we're seeing faster protocols. We're seeing these fast scans for things like ruling out osteomyelitis, looking at ventricular peritoneal shunts. So we're doing things quicker for many of these patients. And then here in nuclear medicine, where you can see where we're reducing the amount of dose and getting diagnostic quality imaging. One big area that is lacking is what I mentioned is the data sets. So these generative adversarial networks can be used to create synthetic data. Since we don't have a lot of pediatric data sets, we may have the opportunity to develop synthetic data. So everything from CT, MR data to help train future algorithms for for indications that we don't have a lot of data for, or institutions that haven't submitted data sets from their particular sites. One area that many of you probably already use is AI to triage work lists, where the AI system is looking for abnormalities on imaging. But this is sort of a tricky area. This is an actual memorandum from the ACR regarding these risks around triage algorithms, because children are recognized as different than adults. And also, a lot of the tools that are used to identify abnormalities are adult-based. So you may be inadvertently putting adults that have diseases over pediatric patients that have diseases on these triage mechanisms. And again, one of the big issues is day-to-day is PACS hanging protocols. We've been pushing vendors to use AI to help us match comparisons and hanging protocols. I have yet to see one that does it perfectly, but there have been movements in hanging protocols and some of the PACS vendors. And then, at least reporting, and this is sort of a whole other area that has just sprouted over the last 2 years. We hypothetically, mentioned this automated way of reporting, into the EMR, but using AI assistance and also hanging protocols. Now we get into sort of the more things, the things that many of us already think that AI does, including the pixel-based or interpretive disease detection and prediction. And you can see here's a litany of examples of where the AI could help with pediatric-specific diseases. This is a list from the ACR use case list, including things like craniosynostosis, child abuse, so determining fractures on skeletal surveys, pneumatosis and free air for patients, neonates that have necrotizing enterocolitis, scoliosis, which is still a very voluminous type of X-ray study that's performed at any pediatric institution. We have the ED VP shunt malfunction that can be used to be determined if there is a malfunction, leg length discrepancy, pediatric hip, and skeletal abnormalities like clubfoot. So this is just an example of a leg length exam. And you can see here there is a metallic ruler. And as a radiologist, we go and measure each of these long bones and give a total measurement. And that can be very time consuming. And also, depending on the reader, it can be potentially inaccurate. So you can see here there are tools, like this was in radiology in 2020 by Zhang and others, looking at segmenting out the bones, which again, segmentation is very straightforward in 2024, but to then be able to create an automated measurement of the leg length and look for other areas and things that if the knee deviates from the mechanical axis, for example. But you can see here that this would save a significant amount of time and add more precision. This is work that was started in 2017 and then was validated at a multi-institutional trial or a multi-center randomized control trial using bone age algorithms and doing this over multiple institutions and really proving that bone age can be, or AI can be used to determine bone age. And now we're starting to see these commercial entities and FDA-approved devices and everything from Bone Expert to Gleamer Bone Age to 16-bit physis, which are all available in the market today. This is another Gleamer product, BoneView, look at where they have FDA approval for detection of pediatric fractures. So there's the without and then the with AI showing you the fracture of the first metatarsal. There are more recent, so this is September of 2024, additional pediatric fracture detection solutions. And, just a comment about these solutions, I think that they are more geared toward institutions that may not have pediatric subspecialists and need another tool or a second pair of eyes to help determine if there is a fracture. These next slides were kindly donated by Dr. Blummer, who had recently spoke at the RSNA regarding the current state of pediatric radiology in the AI market. As you can see here, there are many radiology approved devices, quote unquote, but basically of the AI models listed in the pediatric category, 4 of those 25 are solely in the pediatric population. Those include things like bone age algorithms, hip dysplasia algorithms, and dental X-ray algorithms to detect caries. The other 21 are for use for adult and pediatric patients. So given the lack of pediatric radiology-specific AI models, some have questioned the feasibility of using adult AI models in pediatric patients. So these are the types of apps, again, just to give an overview, like CAD-T is the triaging mechanisms, which I showed earlier for detection, so CAD-E, diagnoses, CAD-X, and processing, so the MIPS, which are regulated by the FDA. So all of these tools are regulated by the FDA using the SAMD pathway. And it's the most highly visible form of AI that we, see both on the news and anecdotally, and it's referred as pixel-based AI. There are non-image-based models, which I've talked about, everything from scheduling to denoising and other tools which are not regulated by the FDA, but have broad applications within radiology, including workflow efficiencies and operational AI. So what is the role of the FDA currently is to clear medical and surgical devices for marketing. But what's very interesting, and is if you get into the pediatric space, whether it's in interventional radiology and surgery or in imaging, there are a lot of these algorithms that are used for adults that are being used off-label in children, and they have not been validated for use with children, similar to how you would test, drugs. So, for instance, the drug pathway for the FDA includes children and adults, whereas some of these other devices are not regulated by the FDA. So the FDA does not regulate the practice of medicine. So people are potentially using these algorithms for pediatric use cases already. Now, this off-label is tricky because, like I mentioned, unlike drugs, there's no legal requirement that medical and surgical devices be studied in children as a part of routine development. So many of our pediatric subspecialists and primary care physicians basically jerry-rig devices that are used for adults for children. So it limits the available medical and surgical devices designed specifically for children. And so we've seen off-label use of medical and surgical devices, and now we're seeing that push into the AI applications. Here's an example of using an adult AI tool to assess for pediatric vertebral body compression fractures. So what the Al-Qahtani saw with this algorithm, that it did not reliably or sensitively diagnose vertebral compression fractures in children. Other work in 2020 that the summary was that it was not reliable method for identification of mild vertebral fractures in children. So you can see here the danger of using adult-based tools in a pediatric setting or for pediatric patients. Thyroid nodules on ultrasound, testing the ability of adult algorithms to discriminate between benign and malignant thyroid nodules. And many of you use things like LIRADS for liver, interpretation, or TIRADS for thyroid interpretation. And there are multiple papers talking about whether there's reliability in using that methodology and schema for pediatric patients. So you can see here the specificity for pediatric malignant thyroid nodules was only 36%, which emphasizes the lack of generalizability of these of performance and related to pediatrics. Chest X-rays, probably the most commonly imaged part of the body. They used adult algorithms to test pediatric patients. And you can see here that there is better, sensitivity and specificity overall with these. They excluded children less than 2 years of age and those with cardiomegaly. So you can see here as that image that I showed earlier, where a newborn chest looks much different than potentially even a 2-year-old or a 5-year-old. So there are changing, and there is changing anatomy over time. So the adult trained models adequately detected pneumonia in pediatric patients aged 1 to 5 years of age. But the models that trained exclusively on pediatric images performed better. So we obviously see when you right size the data sets or you curate it for that specific patient population, it works much better. Intracranial hemorrhage on head CT, there was acceptable performance for the detection of intracranial hemorrhage. But again, what is acceptable to one institution may not be acceptable to another. And then we don't really compare these to, for example, human versus AI. But there was a high false positive rate, which is expected in a screening or triage tool. So you may want that high false positive rate where there is oversight by a radiologist. However, if you have autonomous AI and you have this high false positive rate, you will be referring a lot of patients for surgical consultation. So the summary of these pixel-based or interpretive AI tools is that there is a lack of straightforward generalizability of the adult algorithms for the pediatric patient population. And we need detailed subgroup analyses when evaluating the performance of AI developed for adults and children. Now, the question is, should we use adult AI algorithms off-label in the pediatric setting? I think it should be used with caution. You should tread lightly and have an infrastructure. If your institution or your group wants to do that, there has to be some mechanism of oversight and surveillance. So validating post-deployment surveillance and also using expert readers to be able to determine whether or not that the AI is good enough, quote unquote. Does the clinical use outweigh the potential risks? So are there places in the world or even in the United States where you just don't have the ability to have pediatric radiologists or subspecialty reads at 3 a.m. Where the AI could be a net gain versus not having any AI at all or any radiologist looking at the images. And then the non-pixel-based apps have broad applicability and can be trained on end user and institutional data. So checking with vendors, but using the same methodology as pixel-based applications. So there are many different, you have to really proceed with caution and have governance around how you're going to deploy these tools and use them. What does the future hold? Again, we have these AI models which are heavily curated on data that's been labeled and categorized, but a lot of that data is not pediatric based. Are we going to be able to generalize these tools for use in adults and children? And should it be mandated that some of these tools should have pediatric data sets? And then as I mentioned earlier, using these GANs to create synthetic images to be able to create better models and algorithms and determine, those deep fakes or even hallucinations that we see in AI. Now getting into the reporting side of things. So that was sort of the overview of pixel-based opportunities. Now, we're getting into sort of structured reporting. And many of you have been, either to some of the major meetings or even coming fresh from RSNA. There is a leap now of taking the AI pixel-based algorithms and creating automated reporting. And so this was sort of the schema and the dream, let's say 5 to 10 years ago. But now we're seeing it come to reality with large language models and generative AI. And you can see here that generative AI and large language models sits in this area of NLP, computer vision, and deep learning. And so many of you have used things like ChatGPT and Gemini and Claude. And I'll talk about some of the use cases of where it could be applicable to pediatric radiology. So these breakthroughs have drastically changed the way we approach content creation, and also, including things like creating content like audio and code and images and text simulations and videos. And it's very hard to discern whether it's real or not on some of these. And, there are also things where you can feed these AI systems with papers and create a podcast with voice and going back and forth between two AI people. So ChatGPT, the initial entrant to the LLMs or generative AI, is the Kleenex of of LLMs. This was designed and developed by OpenAI. That's trained on a large body of data, allowing to recognize complex language structures and contexts, and creates coherent and grammatically correct responses to a wide range of queries. And there's a whole art to the prompt or the queries, which I won't get into in this talk, but it's something that does require a little bit of back and forth and trial and error. So these are some examples, explain quantum computing in simple terms, capabilities, remember what a user said earlier in the conversation, and limitations may generate incorrect information, may produce harmful instruction or biased content, and may be limited based on the data set that it's using to provide the answers. So you can see here, these are some of the prompts, and you can iterate over time with those. These are the many players in the LLM world. As you can see here, everyone from Google AI, OpenAI. I thought this was I never heard of Hugging Face, but it sounds like a great company to work for. And then we get into what are the uses by pediatric radiologists with these generative AI tools. So I personally use it as a knowledge resource to help create differential diagnoses based on what I'm seeing on imaging, and using it for things like references, like nomograms and cancer staging schema. So whatever I need to look at, what is a normal kidney size for a 5-year-old, I can just go in and use these LLMs and quickly find the answer or get right to the specific answer without doing a Google search. Radiology report synthesis and simplification. So there are companies that produce a standardization of both report terms, removing unnecessary or ambiguous terms, and then automating, generating impressions and recommendations. And many of you probably are already using these tools today. So this is just an example. This was from the 3.5 days of ChatGPT, differential diagnosis of a lucent bone lesion, the proximal tibia in a child, and gives you a nice differential. It's pretty exhaustive, but hopefully you're able to go back and forth and determine which are your top differentials for that disease. And then things like a nomogram, what's the average kidney length in a 10-year-old? And this chart comes up, which is very helpful. But imagine combining this LLM with the reporting systems that we use to automatically insert this into the report. And then also fixing, things like the way that I report, or using or removing unambiguous terms, which leads to a lot of uncertainty in reporting, both for the referring physician and for families. So this was just a nice way of dictating a report and then having it put in a very nice format. One of the companies is this Rad AI Omni, which takes this model, fine-tunes the data, and pretty much gives you an impression or a summary of your findings. So imagine not having to put a summary to all your reports, which saves a lot of time over the day. And this is just a typical radiology report where all of these things should be, automatically put in from the electronic health record, or at least from your co-pilot. And then if you, let's say, automate the findings, or as many of the findings from the AI tools, and then also automate the impression, you can see here that could save minutes to hours in a day. The referring provider, so things like looking at appropriateness. I talked about the appropriateness criteria and standards of selecting the correct imaging exam. We've all heard of ALARA, so using as low as as low as possible radiation, and translating significant report terms. So not having those ambiguous terms, or at least having explainability around those terms. So you can see here in the appropriate decision. So a 5-year-old presents to the emergency department with headache. Should I perform any imaging to determine the cause of the headache? And so these are some of the criteria and what to consider for whether or not to image the child. Do they have any of these findings? What imaging should I perform on a patient with bilious vomiting? So you can see here giving you things like the X-ray, ultrasound, CT scan, upper GI, and when those are indicated. So it can be a tool to avoid potentially the need to consult the radiologist, but I still think that they should, which we do still have in the pediatric setting is those consultations. But at least if they order a study using these LLMs, they may get to the right exam initially. And then the patient, the translation of significant report terms, the explainability of radiology report terms, understanding follow-up recommendations, researching medical resources, where to find care, and who to go see as far as a subspecialist for those diseases. This is a very nice report out of Scientific Reports earlier this year. So patient-centered radiology reports with generative AI adding value to radiology reporting. But you can see here, it can be a little bit tricky. So I put in, my radiology report states that I have atelectasis. Is that important or concerning for my health? And obviously, we probably say atelectasis with a majority of our X-rays, especially in the inpatient setting. And the AI reported out, in rare cases, atelectasis can be fatal. So that could be probably misconstrued or misinterpreted by a layperson if they put that term in their LLM. What doctors can treat my child's urinary tract infection. So giving you the description of the different providers and who to go see and what they do. So the pitfalls, as I mentioned, are, trying to avoid putting any patient or personally identifiable or confidential business information, because that information is being sent to servers that are not supervised or not protected. But there are companies like ChatGPT and OpenAI that are you can sign BAAs or business associate agreements to allow a more local version of that, where we're seeing that now integrated in EHRs and other tools, validating the accuracy of any content developed by generative AI when you rely on that product to make decisions or perform your job duties. And then generative AI is highly fallible, right? And it can be very convincing. It's very authoritative. So we have to be very diligent in determining when AI is giving us false information or just trying to gaslight us or BS us. The other things like introducing bias. So like how you do the query prompt can change the whole trajectory of where the AI goes. And also the discriminatory and exclusionary effects. So we don't have a lot of the references that AI and these LLMs are using when determining and spitting out this authoritative prose. Some additional resources. This is actually the role of ChatGPT in radiology with a focus on pediatric radiology by Dr. Biswas. This was back in 2023. It has some good use cases on things that I did not mention here. Automated billing for AI, getting into other things. We're seeing more vendors using AI to do coding and medical billing, which is obviously essential for reimbursement. And then what are the opinions, or what's the international opinion of AI in pediatric radiology? So this was a international survey of healthcare professionals, and a majority of respondents, and I think this is unique to pediatric settings, is that many, both parents and providers, still want the human in the loop, which I think is very important. So how do we integrate these tools, maintaining the human in the loop for oversight and using it as an aid or augmentation of how we work rather than a replacement? I think that's the current thought internationally based off of this survey. And I think we have to also look back to our professionals and referring physicians and also radiologists is what are the tools that are needed, or what tools would they want to use? Like things like obviously identifying immediate life-threatening complications from imaging tests, or even from reports, or predicting whether a patient needs more advanced care. So where are these barriers in pediatric imaging? And I've mentioned a few of them because of the way that the patient population is different. Also, the provider base is different. So we lack the tools for evidence bases for clinical outcomes. We're generating more diagnostic uncertainty. So, for example, if we have more and more false positives, or we're determining more and more things off of imaging, what are we going to do with that information, and who's going to report it, and how are we going to visualize it to both the referring physician and the patient? We lack well-curated and diverse data sets, as mentioned previously, and we haven't really done a lot of validation of these AI models at different pediatric institutions. So of the tools that are created, they're very curated to the data sets that they're created from, and they're also maybe overfit for certain institutions or different demographics. There's the whole idea of model drift and brittleness. So even when you do develop, let's say, a good model, there may be drift of that model over time, depending on the input and output variables. So the concept drift, and there's data drift. So things like changing scanners, changing the contrast doses, changing protocols, and also changing patient demographics. Concept drift, certain patterns in a chest X-ray may no longer be bacterial pneumonia. So there may be new diseases that the AI has not trained against. And then the brittleness can occur if these algorithms fail or become unpredictable where the environment changes. So if they're not generalizable tools, they may fail in other settings. So this pediatric AI task force, and I want to talk a little bit more about this specifically. This is a group of institutions and radiologists that have come together to really recommend useful AI tools. So, many of the tools that I've showed that are FDA approved are because we have data sets around those types of imaging, and really wasn't thought through on whether they're going to be used or not, or whether they're advantageous to use. So we're trying to promote the collaboration among members for creating generalizable imaging data sets, just to develop that platform, educational activities for AI for healthcare professionals. So promoting awareness and developing safe data collection practices and storage, and the implementation. So it's a whole 360-degree view of how you create, validate, and also implement, and then surveillance of these tools. So the Society of Pediatric Radiology, the European Society of Pediatric Radiology, the European Society of Medical Imaging and Informatics, the Society of Imaging Informatics and Medicine, the ESR, ARSEN, ACR are all providing this support for this task force. And we'll talk about the charge. So we're really trying to educate not only the pediatric population, but also the adult population on why there should be some equity over time and improving the workforce around pediatric use cases and tool development. The collaborations, obviously, this is a team effort between physicians, scientists, and industry, supporting the use cases. So really directing vendors into things that would be applicable day in and day out, or maybe even be advantageous financially for them to create. The publicly available training data sets, so make them, democratize some of the pediatric information so that the researchers can have access to it. Improving funding or balancing funding for AI, creating standards for AI data and algorithms, and balancing the regulation of AI technology. So we have to balance it out. We can't make it so constrictive that it's almost impossible to do any research or any clinical work in this space. So some of the joint statements, so this is the verbiage, this is sort of hot off the press, it hasn't been released yet, but I wanted to at least expose this group to that. So we have to really look at understand the intended uses of the training data, the AI tools required for the implementation, for the needs of children and their families. So this is through patient and public involvement. And there are many pediatric institutions that have public or family meetings to discuss some of the technologies that are brought into the pediatric setting. For example, as was mentioned, I was involved in release of patient data, patient reports, and patient imaging to families, but we had input from families on whether or not what the timing was, whether they wanted it before hearing back from their doctor. And so there's a lot of different variables that have to be considered when implementing and developing these tools. AI tools intended for pediatric radiology should feature explicit labeling, including the standardized pediatric safety indicator that details the application in children. So almost like informational labels like you have on food that include the safety and efficacy of the data, outline any residual risks of using those tools, and measures, precautionary measures to apply to this vulnerable group. And then promoting partnerships among the pediatric institutions. I think we're starting to see an increase in literacy and AI literacy to help help avoid the perpetuation of biases in knowledge systems related to the disparities, and make sure there isn't unequal availability of both the data and the tools based off of geographic area or a demographic. So there's a level of equity that we have to include while we develop and implement these tools. So strategies must be tailored specific to institutional needs also. So it should be guided by pediatric radiologists, but we have to elevate the knowledge base of pediatric radiologists to understand how to assess these tools, how to create them, and how to interact both with the vendor community and the institution for the betterment of imaging children. The educational efforts for AI literacy must highlight the possible dangers of use of AI in children, especially if these are being considered off-label or with minimal real-world understanding of their performance. So I think this whole off-label or black box use of AI really needs to be brought into the limelight and discussed to determine whether or not we do go forward with it. The ethical and regulatory considerations. So I talked about parental consent versus patient consent. Should patients be able to opt out of continued inclusion in databases after reaching a legal age? Statutes requiring retention of pediatric imaging until a child reaches adulthood. So a lot of institutions are required by law to maintain imaging of pediatric patients until a certain age. And should imaging examinations that were previously interpreted without AI be reanalyzed when AI becomes available? That's another Pandora's box that doesn't just involve the pediatric setting, but the adult setting. Is that once we have an AI tool that can detect additional diseases, do we retrospectively look and determine whether or not disease was present? So the transparency. So we really need to understand the demographics of the data sets and understand that these algorithms were performed with what demographic, both age-wise and also ethnicity-wise, which may have different ramifications, which are outside of the scope of this talk. Statements regarding authorization specifically for use in children, including the description of the evidence that does or does not support the use in children, and ongoing monitoring. So who's responsible for monitoring these tools, the safety, and the quality of metrics of these models? Is it going to fall under the IT department? Is it going to fall under researchers? Is it going to fall under informaticists? This is going to be a heavy lift, especially as we're seeing more and more of these tools being brought to market. The economics, there's not a lot of well-defined structure around AI reimbursement. Only a small minority of pediatric patients are covered by Medicare, which is historically much lower even with Medicare rates. So, the government and Medicare is a major payer in our society, but pediatric patients are very underrepresented in that government payer system. Some AI product manufacturers for adult populations have achieved reimbursement through this new technology add-on payment or NTAP, but it's uncertain how NTAP would apply to pediatric or children-based tools. Assistive AI may have a harder time qualifying for things like CPT codes and the RVU system. Augmentative AI, which produces output that normally cannot be performed by physicians, is more likely to qualify for a CPT code and associated payment. And how are we going to get more and more of this data? So there's this push. It's out of the West Coast to create a pediatric moonshot. So reducing healthcare inequity, lower the healthcare costs, and improve outcomes. And what this is sort of trying to connect pediatric data in basically an anonymized way to make it available. So making it larger than like the NCI data and allowing this information to be shared among AI institutions, vendors, and other pediatric sites. And there's a lot of complexity around this, but it has been already adopted by a dozen or so pediatric institutions. So there is hope for developing this going forward. This sort of last few slides is talking about the image intelligently. So this is a new basically program through the ACR, similar to the Image Gently program, but really focusing on pediatric AI to ensure that AI is used in a safe, equitable, and reliable manner for children. And the vision is to have access so that children will have access and their families will have access to useful medical imaging AI, and that health will substantially be improved with the use of AI in medical imaging. And why should all of you become an ally to this program? And I think I would like all of you to maybe go into the site and pledge, either individually or as your institution, to help promote the safe, equitable, and reliable use of AI for medical imaging in children, and to identify as you go on in practice, or whether you're a vendor or whether you're a researcher viewing this, is to go forward and thinking about that patient population that would benefit from the equitable use and reliable use of AI for that patient population. And this is sort of the pledge site, which all of you can just Google and access. And I encourage you all to do that, or at least spend just 1 minute to go and sign that pledge so that you can be informed about future endeavors in this area. It does take a village, and I wanted to thank a few people, both Dr. Vollmer for a lot of the research done on the FDA-regulated concepts and off-label use of AI, Marla Sammer, who is the chair of this AI Pediatric Task Force, and Christoph Wald, who is the Informatics Commissioner or Chair for the ACR and is the executive oversight of this group. So, but there are many others, which I thank immensely for all the work that they have done. And that is basically, hopefully, we provided a current state. We talked about the use cases, the challenges, the strategy, and the image intelligently advocacy campaign. And with that, I am hopefully ready for some questions.
Wow, fantastic. A real tour of reminding us that children aren't just small adults, and the challenges that we have with AI with regard to children. Gosh, I'm thinking, these tools could be beneficial, as there is a shortage of pediatric radiologists, and many places don't have, including Brigham and Women's. We have Boston Children's, but we are largely an adult, except for the newborn ICU, an adult patient population. So, but it will only work if the moonshot can help and get these models trained and validated on pediatric data. There are a number of questions here, so let's get to them. The first is, let's see here. Could you see a benefit to immediately sending an AI interpretation to the electronic health record as a preliminary result, so that an emergency department attending or inpatient attending could consider it immediately without needing to wait for the radiologist to review it? And notes that this is similar to how many organizations send automated EKG results to the electronic record immediately. The question writer says, I'm not aware of any organization that send radiology AI interpretation preliminary results without first passing through a radiologist. What are your thoughts about that?
Yeah, so I personally think that this is coming. I think that there are a lot of groups looking at, can you say something is normal? Like, can you say a chest X-ray is normal? Can you say an X-ray doesn't have a fracture? I think that we're going to see some of those preliminary reports maybe automating, but then have oversight over humans, especially at sites that don't have subspecialty readers. So, but the question is, what do you call normal? if a patient has, let's say, a little bit of a curvature in their spine, or let's say they have atherosclerotic, calcifications in their aorta, is that something that is deemed normal or doesn't need additional, at least can you have disposition for that patient out of the ED? So I think that'll be a huge help over time. But that is coming, and I think a lot of groups are working on calling something normal and maybe passing it to the referring physician.
Yes, the ability to not detect things, but say something's normal. And of course, we have the problem in the States versus Europe, where our models, the way they're approved FDA wise, is typically one finding, one chunk at a time. Whereas in Europe, you can get many of them approved in one sort of fell swoop. But I'd love to see that moonshot happen, because we absolutely do, and with federated learning and maybe generating or data synthesis with GANs and so on. But this really needs to be done. We have a question about one article you mentioned. What was the title of the study that was regarding patient use of AI and radiology reports? You put up a paper, and I'm not recalling
Yeah,
that.
I can go get that title. It was basically like the patient access to the reports, I believe.
Yes.
Okay, I think I have that.
Patient use of AI and radiology reports was the question.
Yeah, so I think it was out of Scientific Reports, and it was I have the actual, it's called Patient-Centered Radiology Reports with Generative Artificial Intelligence, Adding Value to Radiology Reporting. So, you can imagine using these LLMs to create different reports for different audiences, right? Or making a patient-centric or patient level report of the, and then we're starting to see that with like labs, trying to explain laboratory values. We really need to have better understanding of explaining radiology reports and some of the terms. And as you saw, atelectasis said that it's possibly can cause death, and we probably don't want to communicate that
A
as a
lot of
possibility.
scary terms, and
Mhm.
maybe the parents are a bigger concern than the pediatric patient. Just out of curiosity, have you discussed with any of your parents of patients, have oftentimes when we talk about data being used for research, many patients are very amenable to that. And yes, I want to help the research go forward and so on. But, pediatrics is a little bit a different use case. Are you finding a large concern there, are patients willing to have their children's data become part of studies?
Yeah, I haven't heard any pushback. I think they want to keep the privacy. But when we do go and consent, a lot of the IRBs waive that consent when we're doing just retrospective, de-identified kinds of studies. But prospectively, I've found a lot of patients, both on the maternal side and the pediatric patients, their parents, they really don't have an issue, and they know that it's being used for something that they may be able to use in the future.
Yeah. Yeah. And another question here, since there are AI models approved by the FDA, is the interpretability of the model not a critical benchmark? So is interpretability, and the FDA does not comment on that, quite
Yeah,
honestly.
like the interpretability of the tool or of how it's interpreting the study.
Yeah, I'm not
Mhm.
sure whether interpretability of the model, whether they mean explainability of how the model
Oh,
works.
yes, that's very interesting. I think that they're basically testing it on a data set, and they're showing that it can identify in this, setting, let's say a pediatric fracture. I don't think that they're explaining how it's doing that,
Right.
right? I think they're saying we have this data, we developed this AI tool using, generative or whatever AI tool or cognitive neural network, and this is the output, and it's consistently finding these diseases. But I don't think that we're required to say what the AI is actually identifying or doing.
Right. It's a very low bar, actually, for
Yeah,
them.
it's a very
I
low
don't mean
bar.
that derogatorily, but but is it safe? Is it comparable to things that are out there and so on? We are up against time, and I want to thank Dr. Halabi for a wonderful, wonderful talk. And I want to wish everyone a happy holidays and a happy new year, and we will reconvene in 2025, January. So thank you everyone for your attention, and Safwan, fantastic. Thank
Well,
you.
thank you so much, Kathy. I appreciate it. Bye, everyone.